Hello, 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 everyone.
Hi, everyone. Welcome to our workshop. We're so excited to see we have about 67 people in the virtual room. Hello, good afternoon. Oh, hi, Mavis from Pacific Community of Alaska. I know her. And Claudia, aloha. Oh my gosh, this feels like a
My great friends.
virtual reunion.
See Carol from California and Carlina from CHWF.
Oh,
A lot of
yeah.
good friends here. Gracie Flores from Hawaii. Awesome.
Yeah, feel free, we're gonna give it maybe 30 more seconds before we get started, but feel free to drop in into the chat box. Feel free to introduce yourselves. We'd love to know who you are and what you do, where you're from,
I
share what
see
the fun
Alabama in
you're
the house.
doing.
Alabama in the house, yeah. Love it.
Oh yeah, mention your state. Yeah, that's right. We're speaking to your friends from all across the country.
Yes. South Dakota, Washington.
Oh, awesome.
Great, great. Thanks, you guys.
Okay, well, I think we can get started. What do you think, LyVesha and Colby?
Sounds great. Just
Yeah,
when
yeah.
the vacuum cleaner gets started, so hopefully you don't hear. Yeah, it's a cue. Well, thanks so much everyone for joining us today. We're really excited to share with you our presentation and really involve all of you because we know that all of you bring such a wealth of knowledge and experiences and really want to uplift those and share resources and ask questions and be thoughtful and hopefully empowering so that we can all leave this session with some nodes of inspiration, some insights, some new resources, some best practices to go out there and tackle this somewhat complicated topic around reimbursement. My name is Colby Takeda, and I'm going to introduce the rest of our speakers in a bit and have them introduce themselves. But just want to thank you all for being here and excited to share some of what we've learned and hopefully make us all a better community of CHWs and allies. I'm going to first have our speakers introduce themselves. I'll turn it over to LyVesha.
Hello, hello, hello. Thank you guys for all coming out here. Yes, my name is LyVesha Franklin. I am a CHW here in Marina, California. I love my work. So I do have to start by saying, in full disclosure, I'm coming to you all today as vulnerable and humble as I know how. So please don't let the title of CEO give you an impression that I am an expert. I am not, and I did not claim to be by any means. However, I do consider myself a trailblazer for taking a leap of faith to create safe spaces for all things concerning public health in hopes that more community health workers become the leaders in creating safe spaces in their communities as well. So, being a community health worker is a skill that I feel I was just born with. So, that clearly is the easiest part of what I do. I love helping my community and being of service and creating a positive impact on humanity. So the only downside to delivering great, kind acts of kindness is finding ways to professionalize it, into billable services covered by government insurance in order to be properly compensated. Because, of course, how do you put a price tag on human service? But realistically, in order for me to give my best to my community, I have to be at my best. So that means I have to be able to pay my bills and feed my children. And having these basic needs met puts me in a position to be able to do more for my community. So compensating those of us with lived experience of being marginalized in order for us to have the capacity we need in order to show up for our fellow vulnerable and marginalized neighbors, it's extremely important. So CHWs are delivering the human core healing services, and we deserve proper compensation. And I understand that a CHW certification does not hold the same weight as a 4 to 6 year college degree, but life experiences gives us a skill that can't be taught. And CHWs are still performing miracles. We're still changing lives. We're saving lives. And our work is extremely important to the health of humanity. So no, we should not have to work for free. and there's great value in what we do. So thank you all for joining, and I'm going to pass it to my next co-speaker, Mr. Joe Lee.
Thanks, LyVesha. I'm just so inspired by you, and thank you for all that you do for many communities. Hi, everyone. My name is Joe Lee. I go by he, him pronouns. I'm currently the founder and principal consultant of Community Health Synergy. Just a little bit about Community Health Synergy. We are a queer and Asian-owned small business dedicated to advancing health equity through community-centered capacity building. I also identify as an educator. I teach a wonderful undergraduate course at UC Berkeley about advancing health equity. I secretly try to brainwash all my students to become community health workers in the health and social care field after they graduate. And I previously have worked for a lot of just wonderful safety net organizations, a federally qualified health center, a regional association representing a lot of clinics in the Bay Area of California. I worked for a national association where I co-founded and launched a national CHW workforce collaborative during the COVID-19 pandemic. So I'm a staunch and just really proud ally of CHWs and promotoras and representatives of tribal nations. And I also want to share that my mother is a CHW herself. She is a CHW volunteer at a local small Korean Catholic church in East Oakland. And everything that I do in my work and my personal and professional life is really a lot of my inspiration is drawn from her lived experiences and the values that she's taught me about what it means to uplift communities and to really truly advance equity. So that's a little bit about myself, and I'm just really honored to be in this space with you all, and just can't wait to learn collectively. So I'll hand it over to our other co-presenter and speaker, Colby.
Everyone, it's so great to connect, and aloha from Hawaii. Although I'm not in Hawaii today, I'm actually calling from California. So thankful for my roots in Hawaii and the many work that I've learned and done with the community health workers in Hawaii. I'm myself was previously a community health worker instructor. I taught courses during the pandemic and got to first get introduced to the community health worker space. So I'm rather new to the community health worker workforce, but I'm so thankful for the many people that have taken me under their wing and taught me so much about all that community health workers do. I've since been able to do quite a bit of community health work for myself. I was on the ground in Lahaina, Maui after the wildfires. I do some work with street medicine providers in California. I now oversee a team of about 15 community health workers and a network of about 350 community health workers across California. I also do quite a bit of work with students, just like Joe. So I teach community health courses at a public health school in Hawaii, and also do a lot of work with different associations. So community health worker associations, American Public Health Association, and other industry organizations that are trying to drive public health and community health forward. I also do quite a bit of work with health plans. So I think the perspective I want to bring today is some of the work that we're doing with some health plans to help with reimbursement and helping community-based providers and organizations build those relationships. They're oftentimes hard to establish and develop. And I think the perspective of what health plans are looking for, what providers are looking for, is important for us all to understand if we want to understand reimbursement. And so I hope to bring those insights as well. Prior to my work with our current organization, Pair Suite, I actually led policy and partnerships at the Blue Zones Project. And so we're doing work with schools and restaurants and grocery stores and public housing spaces and public agencies and community-based organizations to really promote health well-being. And so got to travel around the country and support these efforts as we try to improve health and longevity. On the personal level, I do travel a lot, so I love visiting coffee shops. My parents have 2 dogs that I got very fond of, and so I'm a new part-time dog owner, and enjoy all the people that I get to meet around the country. So I'm really excited today. I'm going to kick it off and go into this. I do want to thank, before I forget, our rooms assistant, Sophia. Sophia, thanks for joining us, and then also our interpreter. Thanks for being here to help make this content available to people in Spanish. All right, so here's a big short overview of what we're going to be presenting today. We're going to start with talking about our why. Why are we here? Why is this topic important? Why is this important that all of you learn about the different mechanisms for reimbursement, and then how do we move forward with that? We're going to do a quick overview of what's happening now, the current situation around reimbursement, opportunities that exist, and of course, that will lead into existing challenges. We all know that there's challenges that are present or and perceived and real around reimbursement. We want to certainly discuss solutions. We want to be very positive in this and present opportunities to grow from experiences and learnings from the past. And then hopefully give you some pointers to move forward. Then, of course, we want to leave lots of times for Q&A because I know all of you have great insights and experiences to share as well. And so we want to leave some time for Q&A at the end. And a quick reminder, I love seeing all the emojis and the reactions in the chat, as well as in the with the reaction button. So continue to do those. If there's things that you like or don't like, feel free to drop it in the chat as well. We want to hear your experiences, your stories, your questions. If you have resources, please drop them in as well. We want to make this a community of practice. And unfortunately, this is set up as a webinar style. So if you have questions, we also have a Q&A section. Feel free to put it there or in the chat, and we'll try to get them to them either throughout the presentation or at the end. All right, with that, I'd love to turn it over to LyVesha.
Yes, so our why, we have several reasons for why. I know I mentioned a few in my introduction. And why is this topic important? You know, compensation is very important for CHWs. Like I said, I pretty much put it all in my introduction. Like, in order for us to show up for our community in our fullest capacity, we have to, be able to provide for our families at home, and we have to be able to give from our overflow. So that means, and then there's a lot of unbillable work that CHWs do. So this topic is important, and we need to continue talking about it in order to be able to incorporate those unbillable services under a billable umbrella. So, CHWs do a lot of work. And like I said, it may not hold the same weight as a 4 to 6 college degree, but our lived experience provides us with necessary tools to create safe spaces beyond the healthcare facilities. So can we go to the next slide where we have more bullet points? So one of the key reasons why I personally had to make the move or take the leap of faith in becoming a CHW supervisor and being contracted in order to bill for the CHW services is because I know in my community, there's not a lot of spaces where Black women feel safe. As a Black woman in my community, Black population is only 3%. And that means there's a very disproportionate number of service providers being able to deliver those services and incorporate things such as the history of racism and violence in public health scenarios. So that's one great thing that I love about what I'm doing is I am I'm creating space. Representation matters when it comes to service delivery as a CHW. So I'm sharing this space with my co-presenter, Joe, if he wanted to talk more about these key points.
Absolutely. Thanks, LyVesha. Beautifully said. I just want to, take a step back, and I'm sure many of us feel the same way in the room today. Health equity and social justice are not just moral imperatives. They're so vital to correcting the deep and systemic injustices faced by communities of color who have been marginalized and denied access to critical resources for generations. And when entire populations are overlooked and underinvested, we see it. We have lived it. We're still fighting against these injustices. The cycle of poverty, poor health, the social disenfranchisement, it continues. And so we need health equity. We need social justice to dismantle these barriers to honor the dignity of all people and to build a future where opportunity, well-being, and respect are shared equally by everyone. And people who can and really do help dismantle barriers are community health workers. They're CHWs. It's a profound injustice, in my opinion, when community health workers who are essential to advancing health equity, they're often underpaid or undercompensated. These workers are on the front lines, providing culturally competent care, bridging gaps in healthcare and social care access. And yet their contributions are frequently undervalued. So that's why we're excited to put on this workshop, because we're excited to uplift some meaningful reimbursement models and advocate how we can improve reimbursement and improve pay and really advocate for pay equity, right, for CHWs. So those are just some of my thoughts.
Thanks to both of you. Before I move on to the next slide and move on to the current state, let's remind everyone, if you didn't see it already, there is a poll going up. We'd love to hear, if you're currently reimbursing or utilizing reimbursement pathways for funding now. If you aren't, please also respond to the poll. And if you don't know, and if you're not sure, because maybe it's being managed by your employer, feel free to select that as well. And of course, please continue to drop introductions in the chat. We love seeing that. And if you have any questions, feel free to put them in the Q&A as well. And if we see them and they're appropriate to respond throughout the presentation, we can definitely do so. I saw people being responded to already, so that's great. All right, Sophia, do we have results from the poll you can share?
We do. So we are still waiting on a couple of responses here, but we have about 15% of our attendees saying yes, about 78% of our attendees saying no, and just a small 7% of our attendees are unsure.
Gotcha. Well, that's perfect. That's really great. All right. So we're going to do a quick overview of what's currently happening in the landscape and kind of the mechanisms that are out there and the different situation that we're experiencing. And then we'll go into kind of what the landscape of reimbursement is like. And so, of course, community health workers have been doing this work, not only recently, it's been for decades, right? Community health workers are an established workforce, mighty, young and mighty, but oftentimes relying on grants and other, soft money funding, we call them, things that might be short terms. Maybe they require reporting to a foundation or a fund, maybe getting subcontracts from a government agency. But for the most part, funding has always been a concern for community health workers, hence kind of why we're here today. Other conditions or situations, this has kind of led to staffing being sometimes reliant on short-term contracts. We're seeing a lot of 1099 community health workers. Actually, a couple of states I work with have been trying to build job boards for community health workers because they're constantly jumping from grant to grant once the grant runs out. And so overall, this has led to somewhat limited pay, limited opportunities, limited growth for CHWs, certainly things that we would like to address as we move forward. The role, right? Lots of times the role is misinterpreted or it's unclear for many other providers. You think about a doctor or a nurse, right? They have a clear role and they have a clear scope of work. But for community health workers, they kind of just jump in and do everything, right? They're very good at building trust and addressing social needs and providing navigation services, education. But for other entities or organizations and the leaders of these organizations and other provider types, like they aren't really sure what the role of a community health worker is. I always go to these conferences and present to doctors and social workers, and I ask the room, do you know what a community health worker is? And oftentimes people don't raise their hand because they don't know, and so there's confusion around the role of community health workers, and that leads to healthcare overall not knowing how to partner with community health workers. What are the swim lanes that each of us should be in? How do we partner together to provide comprehensive care? Of course, this confusion leads to misinterpretations around everyone's role, and sometimes trust isn't passed on, or there's confusion around who's doing what. And then this leading to other challenges like we see here, high caseloads, skills of community workers not being utilized, and sometimes they're in the back, stapling papers or just sorting things. This certainly not allowing people to work at the highest level of their role. and of course leading to stress and a lack of growth. So we can't advance in their career and grow. It really holds back community health workers. However, there are some shifting times, right? We're seeing a lot of positive movement for community health workers. There's groundswell of excitement around the community health workforce. Some of this has been driven by current events, everything from political current events to environmental to natural disasters. You think about the pandemic was a huge current event that led to a higher recognition and opportunity for community health workers to step up and really support the efforts to educate, to vaccinate, to provide preventative services, and has really shined a light on the workforce. So that was a positive current event. Other things like the Maui wildfires is an example of an opportunity for community leaders really to step up and show how they can support in critical needs, not just on healthcare, but housing and resources and other things like that. We're seeing a lot of policy change. Certainly, Medicaid has been a big driver of this, but also Medicare, right? We're seeing now more organizations recognize the value of social determinants of health, health equity, and the need for on-the-ground organizations to be involved in this work. Groups like NCQA is now recognizing community health workers and community-based organizations. State Medicaid agencies are finding ways to infuse community-based approaches to care, not just clinical in nature, to be involved. And so all of this work, and of course, the advocacy efforts of groups like CHWs and other groups that are pushing for culturally sensitive, community-based approaches with community health workers is leading to these shifting times. We're also getting a lot of data. There's a lot of organizations now that are doing research. I mean, 5-10 years ago, if you looked up studies on the role and impact of community health workers, there would be very little things out there. And so, of course, for a lot of these big organizations that rely on data to make decisions, without the data, they couldn't make positive movements in the community health worker workforce or landscape. And so we're seeing a lot of great reports coming out, whether it's a white paper or something that was self-reported or evidence-based studies. We're seeing a lot more data out there that's helping to move the needle and have these conversations around community health workers. Of course, that also aligns with financial incentives. So now that groups are actually doing the work and studies on the impact of community health workers, we can actually see the ROI, we can see the outcomes and clinical outcomes. We're seeing adoption of things like vaccinations or screenings. The impact has been pretty awesome. We're also seeing amazing leaders step up and take a stand and say that, yes, we want to incorporate community health workers. We want to support this workforce. We want to get them involved in our work. And that bold leadership is also leading to higher adoption of community health workers and involvement and integration of them into the broader healthcare system. I saw some more friends on the call from this organization, but it's studies like this that's really helping to move the conversations forward. And so shout out to the team at Center for Community Health Alignment for doing, putting out graphics like this. And every time there's publicity or reports or studies out there on the impact of community health workers and the role of community-based organizations, it really helps us all and this industry move forward. So shout out to groups like this. There's also another study I just want to highlight really quickly, talking about costs. And of course, this session today is about reimbursement as a pathway mechanism for community health workers. This is a really interesting study that came out looking at what's the actual cost to run a community health worker program and how much do we have to actually pay community health workers to overcome all of the expenses involved in community health worker programs. This study found that on general, including wages and overhead costs, that $53.24 per half an hour is what was necessary. And that's with some conditions here. You can see a caseload of 1 to 65, and one nurse manager supervising 8 CHWs. And so not every organization has that same model. There's obviously some expenses that are included with in-person support versus virtual care. But it's interesting that these studies are now coming out that are helping us consider what is the actual cost of CHWs and in different settings, and how do we overcome those with different funding mechanisms, which really sets us up for the next conversation around reimbursement and how we all can overcome some of the challenges of getting started with reimbursement. With that, I'll pass it over to Joe.
Thank you so much, Colby, for sharing these really critical resources. I know there's one of the folks in the chat are interested in receiving copies of these documents. So what we'll do is we'll find links to these documents and drop it into the chat box so that folks can have some fun reading after today's workshop. So for this current slide that we're viewing now, I want to give a shout out to the Connecticut Health Foundation, one of the consulting groups that were funded by the foundation. They conducted a 50-state scan of Medicaid payment for CHWs. I'm just going to go through some high-level summary of this 50-state scan, and for everyone's kind of education and awareness, I'm dropping in the link to this publication of the 50-state scan. Currently, we know that as of January 2024, 24 states currently pay for CHW services through Medicaid. And the payment for CHW services do vary. The payment varies based on what services are covered, what populations can receive covered services, such as pregnant people, children, adults with chronic conditions. There are various types of payment methods and rates and authorizations. And we have learned from this publication that most states cover the following CHW services. They include care coordination, systems navigation, health coaching, patient advocacy, clinical support, and community outreach. And we are also learning that there is no clear standard for payment rates across the country. In fact, the payment rates vary across the country from $9.70 per 30-minute kind of encounter or service to $35 being the highest kind of fee-for-service rate. On the next slide, for those who are visual learners like myself, this is a really nice kind of map of the continental US and Hawaii. And you'll see in green the states that currently pay for community health worker services through Medicaid. So you can see here that there are a lot of states that are not currently reimbursing or paying for CHWs and promotoras and representatives. So we have a long way to go to advocate for payment and reimbursement in states that are not currently paying CHWs. On the next slide, I want to briefly provide a high-level overview of the various types of payment models that states are currently following for those that are paying for their CHWs. And for those who are from states that are not yet receiving reimbursement for CHW services, this is really great information to learn about the various payment models. The person who just asked in the chat, when was the map updated? That map was updated as of January 2024. So I know that it's August 2024, so there may have been some new changes and some new updates in some states that that were not reimbursing kind of CHW services at that time. No problem. So let's look at the fee-for-service model. This is also known as, there's a lot of acronyms in healthcare, as we all know, FFS, so fee-for-service. If you take a closer look at the publication, currently 8 states use a fee-for-service payment model. You'll see that these states use very specific billing codes. The most common kind of billing codes are CPT billing codes. I'm going to spare you the lecture and definition around the current procedural terminology, CPT codes. But long story short, often doctors and healthcare professionals, they use some kind of uniform language and to code specific procedures to streamline reporting, to increase accuracy and efficiency. So you'll see CPT codes being used to define specific that are mapped to specific CHW services, and they're often billed in 30-minute increments. The second payment model is managed care. So there are 6 states that cover CHW services only through managed care. What do we mean by managed care payment model? So one example is that CHW services, some of the managed care organizations, they provide enhanced per member per month, or also known as PMPM payment. And this is something that managed care organizations use that provide managed care organizations that provide access to CHWs to their members or their patients. And states that use this methodology include states like Massachusetts, New Mexico, Oregon, and Washington State. And there's about a few states that give managed care organizations the option to include CHW services as part of their care management programs, but do not require or reimburse for their services. Now, you'll see in some states, the third circle on the slide, some states, 5 states cover CHW services both through fee-for-service and managed care models. And then, interestingly, West Virginia is the only state, the one and only state that covers CHW services as a monthly capitation for certain pregnant and postpartum folks. And their monthly rate is about $207 in West Virginia. So this is really interesting that this approach, this monthly payment rate, actually has been used for other paraprofessional services, such as recovery coaches and peer support specialists, as well as behavioral health wraparound services that include care coordination and family and peer support. So I hope this is helpful. This is really just like a high-level summary of the payment models. There's a lot of like detail, right, around how payment eligibility is determined and what kind of services are covered and how the authorization processes go. But I hope this was really educational and helpful. At least for me, this was really, really eye-opening. So kudos to the Connecticut Health Foundation for doing this fabulous kind of landscape. And we'll be sure to put in more links where you can learn more, from your own, state where you currently reside, how you can take advantage of these payment models. And if there isn't a payment model, hey, maybe you can advocate for a particular one that could work for your state. So I'm going to pass it back to Colby.
Yeah, and just to highlight some of the questions in the chat, it's just interesting. There's and we'll talk about eligibility in a bit, Karen. So that will be definitely a big one. We're actually seeing some states where, because they don't have reimbursement formally created through some kind of state plan amendment or some kind of policy change, it actually allows them more flexibility to work with health plans to pay them different rates. So they don't have to abide by any standard rates because there is none. And so sometimes these could handicap the organization from negotiating rates because there's nothing stopping you from going to a health plan and saying, hey, we can provide a service that's really valuable, and the health plan can recognize that value and provide you the compensation that you need to run this type of services and pay and cover your staff. So yeah, other opportunities. So kind of back to Sarah's question around what are we seeing the best rates? I mean, sometimes the best rates are the ones that don't have rates because we can then negotiate rates and get more than what you need.
Yeah, and thank you, Colby, for pointing out the chat. And I mean, I know Patricia, you acknowledged that you work for Inland Empire Health Plan and you get paid from them. So yeah, in California, I think the payments can come directly from the state or the managed care plan. So that's really unique in California. Julie says, "Yeehaw, go Maine!" I had no idea my state did this, so that's gonna be great information from us. Yeah, so Maine does reimburse. So please pursue that reimbursement. And Colby linked in another really great tracker by the National Academy for State Health Policy. This tracker was actually really supported by Carl Rush, who's a nationally recognized CHW advocate and consultant. And Renee says, yes, it's all about those CPT codes. So yeah, get to know the CPT codes because that does really help, especially in the fee-for-service model. So thanks and Mavis, advocacy. Yes, we do need advocacy for higher rates and universal kind of payment models in all states.
It's important to also note that not every CHW, if you have the title or not, can utilize some of these reimbursement codes. It all depends on which setting you're in and what that specific reimbursement policy allows. So some organizations, for example, if they're in a federally qualified health center, you may not be able to utilize this because the reimbursement that your organization is getting and the payments you're getting already includes things like care coordination, health education, resource linking. So it all depends kind of what setting you're in and what kind of work you're doing and the scope of that work. All right, so now go for it.
And yeah, I also saw in the chat, Sarah asked, out of all of the models, which one did we think was the fairest? And I have to say, now I may be ranting a little bit, as a CHW, as someone who eventually hope, and my intention is to hopefully be in a position where these reimbursable services become my main source of income. So therefore, I am advocating, as Mavis said, that's what we really need to do right now, is advocate. So personally, I do not believe that there is the fairest model has been created yet. There are great models, and while even though I'm in the work and I'm doing the work, it has not reached a level of fairest yet, because there's so much that goes into CHW work that is not considered billable. So the advocacy is very important to be able to put all of those services under the billable umbrella. So unfortunately, right now, I personally don't believe that there is a fairest model yet created. And that's why these conversations are important, in order to be able to create the model that CHWs really deserve, considering the amount of work that we are doing. So there are great models, however, they can be greater with advocacy.
Yep.
I couldn't agree with you more, LyVesha. And there's a really great question about, if oh gosh, let's see, if we've heard of a spectrum of value-based payment arrangements. And what's interesting for the fee-for-service model, Medicaid only pays for services delivered. So this minimizes the risk for either the state or minimizes the risk for the state overpaying or providers receiving a payment that does not cover the frequency of services provided. However, fee-for-service is not a value-based payment strategy. So it could result in payments for services that do not provide the outcomes desired. So there are some challenges. There are some advantages, but there's some challenges, to LyVesha's point, for each of these payment models. And we do need to, I think there's an opportunity for us to create a model that is holistic and equitable, and something that really truly recognizes the hard work that CHWs do day in and day out.
Yep. And definitely don't want to forget there's other, insurance types that also is reimbursing. So Medicare also has reimbursement now, and commercial health plans are reimbursing for community health worker services as well at different rates. And so just giving different opportunities there. And next, actually, I'll go to the next section, and we'll explain more about some things I wanted to mention. But the next section is going to be me and LyVesha kind of explaining California as an example, because I think lots of times, and we go to these conferences, we hear about these policies, but we actually don't know what does it mean? How do you actually operationalize these policies? And what does it mean to be a community health worker on the ground? Like, what's your role? What barriers might exist? And how do we actually get the money in our bank? So we're going to give California as the example, and there's a lot of people from California on the call. So definitely feel free to chime in, but this is just a simple example around CalAIM and this new community health worker benefit in California. And so just for more background, LyVesha shared that she is an independent CHW organization. She's trying to do this on her own. I work at an organization that supports lots of CBOs and small organizations, community-based organizations, try to become a billing entity. But also do a lot of work with health plans and providers, and kind of hear, from all walks of life, like what's going on, how is this rolling out, what are the challenges, why aren't people doing it, why are people doing it, once they get started, what are they seeing? So I just want to share some of those insights here. But essentially, the community health worker benefit in California was under the umbrella CalAIM program, and this is all about addressing social difference in health and impacting whole person care. So how do we move the needle forward with addressing social needs, using a workforce that's already in place and can really enhance the work that health plans and health systems are already doing. And so one of those is the community health worker benefit. And I like to break it down into these 5 components, and the health plan partners on the line might scold me for this, but I think it's really simple as 5 key components. You have to have a supervising provider, which traditionally had to, you think about supervising providers as being a clinic or a hospital or someone with a medical license or degree that can practice medicine. But now in California, and this is why LyVesha has launched your work, is you can actually be a community-based organization. You can be an organization that's maybe a nonprofit, maybe an entity that's working on other types of health and social needs of the community, but traditionally doesn't have a clinician on staff. In that supervising provider, you would have a CHW, and there's certain requirements of what qualifies a community health worker in California under this specific policy. You have to work with the managed care organizations. So the managed care organizations are the health plans providing Medi-Cal services or Medicaid services to members. You have to work with them. You also need, the fifth component is a licensed recommending provider, someone to recommend that a Medi-Cal member needs these services. And you also, of course, have to have the component of the member itself. So the member has to be an eligible Medi-Cal member who's enrolled with a health plan. So those are the five key components. Of course, there's more nuance to that, but I'd like to break it down as 5 things. Okay, so first off, who is it for, right? So these are the current eligibility requirements for what kind of Medi-Cal member could qualify for these services. And I like to always present this as, look at this long list of options to help someone qualify. So I think the state is basically saying, we don't want to create barriers. We want to make it easy for someone to qualify because we know that everyone can benefit from health and social services, right? We know they can benefit from care navigation, resource linking. I always like to call it this unmet social needs. Like, who doesn't have an unmet social need, right? Most times people can qualify under that one, if not one of these other categories around ACEs or a previous history in a detox facility or any of these other needs. Next, what is covered? Again, I'm just quickly going through this so we can get to the next section, but these are the 4 main categories of what types of services that a community worker provides that would be covered under this benefit and get reimbursed and get paid for this work, right? And again, this is, like Joe mentioned, a fee-for-service model. So if you do work, you get paid for that work, right? As long as it meets the eligibility. So any of these services you get paid for. Health education, providing some kind of information or education around health topics, health navigation, helping to provide referrals or support or information to get that person to overcome any health and social challenges. Screening and assessment, conducting, maybe it's a social needs screening or understanding those needs on a one-on-one basis. And then of course, advocacy and support. And that can include prevention of violence. And so those are the 4 covered services. And of course, these are also very broad. And so it's meant to, I think, include lots of different types of organizations and the type of work that they already are doing. In California, the current all plan letter, which is the policy by which this policy exists, allows for about 2 basic pathways to get credentialed to provide services. The credentialing isn't a certification yet, it's just a credentialing that says that this community health worker meets the requirements or the pathways to become certified, or not, sorry, take it back, ignore that, to become credentialed. The CHW has to first have lived experience and either have a completed CHW certificate of completion, which includes field experience, or have the work experience. So 2,000 hours of experience within the last 3 years in either a paid or unpaid setting. So right now there is no standard certification in California. And so as long as you meet one of these criteria and can prove that you meet those needs, either to the health plan that you're working with or internally, you can actually provide these services. Next is, what does it actually mean for the organization? So what can we get paid? So right now, these are the 3 CPT codes that are used. So if you provide services on a one-on-one basis to one patient for 30 minutes that you get 1 unit, you can get paid. Oh, these are different rates. Sorry, these are a little bit different, but it's actually $26.66. These are actually adjusted, I think, for Sarah's health plan. But yeah, you get $26.66 per half an hour in California. And if you work with multiple patients, you can actually bill for each of those patients at a lower rate, but because you're working with multiple patients, you can still get paid for each of them. So for every Medi-Cal member, you can get paid a lesser amount. So right now it says $13.29. And then of course for 5 to 8, you can get paid a lesser amount, but again, you can bill for multiple members. So that's what allows for this. There are some restrictions on how often you can bill and requirements listed here. I also mentioned that there are different health plans providing different rates. So they might be paid more or less based on which health plan you're with and the percentages they want to pay of these rates. And I'll turn it over to LyVesha.
Yeah, I wanted to respond to Sarah in the chat because that's the position that I'm in right now. So right now, I am a CHW. I've worked for other CBOs prior to becoming my own contracted. I'm contracted directly now with CCAH, and that is the biggest challenge. That's why I sign up to speak at events like this. That's why I advocate. That's why I'm doing everything that I can to be able to help increase that reimbursement, because like you said, there's a lot of work that is not even considered billable. So like the rates, like you said, it only covers 50 to 60% of the operating costs. It does not cover transportation, does not cover research, it does not cover all of the additional support. And then another barrier is having that referring professional also that a lot of independent CHWs don't have access to. That's where collaborations like the one between myself and Joe and Colby really help make things work. And also some managed care plans offer grant funds for for building this workforce. So that's one thing that hopefully helps me in applying, being able to provide other positions in other spaces for CHWs to help be able to compensate them fully for their time. And then on the back end, as a supervisor provider, as me as the community-based organization, being able to bill for the services that they deliver as CHWs, then that reimbursement is what I'm hoping to create sustainability for those positions, those CHW positions. So there is some soft funding available. There's grant funding available to help offset those costs that are not covered by reimbursement. But again, it's still a lot of hard work, and it's a lot of advocacy, and it's a lot of, having these conversations in these spaces. And this way I can segue right into our next screen, which shows this number of 7,000. So globally, well, nationwide, only 7,000 Medi-Cal members have utilized this benefit out of 15 million. So this number really speaks volumes on the importance of getting the word out and connecting community-based organizations with medical institutions so that we can not, just because this service was adopted, there's still definite gaps and steps that need to take place in order to spread the word and increase and raise awareness of this benefit to reach more of our vulnerable and marginalized community members who can actually, greatly benefit from this this benefit. So with that being said, we just ask advocates and supporters of the CHW work who understand and know the importance to please continue to advocate in these other spaces and show, that there is a huge need. And we want to be able to partner like CHW. We're out here. We want to do the work. And currently, in order for me to maintain as an independent CHW, I have to have contracts to continue to deliver CHW work while I'm building this infrastructure to be to just rely totally on the reimbursement. Right, currently as it stands, no, it's not enough. It's not enough to function. But like I said, and then another barrier, I know we're probably going to get to it, so I'm not going to touch too much on it, but it was touched a little bit. Colby mentioned the enhanced care management and community support services. As a community health worker, I'm contracted with another company to deliver the enhanced care management and community support services. However, I'm still delivering what falls under community health worker services. However, the two services cannot overlap. So it has to be one or the other. And enhanced care management is still, it's a very thin line between community health work support and enhanced care management. It's pretty much the same thing, but the two services can't be overlapped. So that's also another challenge. And I would love to be able to separate the two and be able to provide the CHW work and then the enhanced care management work on another playing field, but that's another barrier. So there is a lot of challenges to CHWs becoming independent and being supervisor, but there's also a few opportunities like the grant funds and other soft areas. And like I said, more conversations and webinars like this that will increase opportunities for more funding resources to come in. So yeah, and I'll start. I don't know if this is my slide, I don't know, but I'm going to start with the challenges in California with the multiple NPI types. There's two different NPI numbers that you can get. One as a sole proprietor, which is what I'm doing, and then one as an organization where you can submit claims for multiple community health workers underneath that one umbrella. So, and again, like you said, there's a lot of startup costs in becoming independent and doing it that way, but there's also a lot of opportunities, meaning we can, as CHWs, we can create our own like workflow and our own plan. However, unfortunately, where we stand right now, not all of our services are billable. But we want to be the change to make that happen. So it takes for us to actually get out there and do this to show how important these other unbillable needs, need to become billable. We have to do it. We have to collect the data. We have to gather the data. We have to make the change and just kind of take a leap of faith, and then hopefully, managed care plans can catch up to what we're already doing, but we can't just talk about it. So right now, I'm just hopefully inspiring more people to do what it is I'm doing so that we can, be on the other side of history and revolutionizing healthcare delivery as we know it, and changing the narrative, being the leaders to change the narrative instead of waiting on something to happen. Let's make it happen. So, all right, I'll pass it to another speaker.
Yeah, just wanted to call out some other challenges, and some of these will be mentioned further along, but these are just some challenges that I think our group kind of thought in California could be a barrier for some organizations, including not having the right insurance to cover your organization. There's some health plans that require a certain amount of insurance, whether it's cyber insurance or $5 million of overall insurance, general insurance, and that can be a barrier for smaller organizations. Current codes in California don't cover transportation costs. So if you're going to do home visits, the time it takes to get there and the time to get back to your office isn't covered. Every health plan has different credentialing requirements or processes, and that's actually a common one across the country as well. And then sometimes the reporting requirements of health plans are timing. It takes time intensive, and so that cuts into the money you make from these. Joe, anything else to add to this before we move on to the next section around other challenges?
No, you both have covered it all. I do want to acknowledge the amount of time that we have left. And so we're just shy about 15 minutes left. And so I want to just propose to Colby and LyVesha just on the spot, if we could maybe summarize the next slide around the top challenges and kind of breeze through at least one solution per challenge area. And then because we would love to get to some of the questions and engage with the audience here today. So I see your nods. I'll just kick us off. I think the top challenge obviously here is from what we hear from a lot of community health worker employers and CBOs and across the state and across the country. There's a huge change in how organizations have to navigate from grant-based revenue streams to a hybrid of grant and claims-based reimbursement. And so this reimbursement kind of environment can be uncomfortable. It could be, something that folks have never done before. And so we want to acknowledge that. And one of our top questions is like, hey, what's a CPT code? We've never had to use a medical billing kind of terminology. And then the second challenge here, the health policy arena is really complex. There's a lot of key players that kind of help advocate and help implement the CHW benefits or the reimbursement policies. And you have your state and federal government involved who authorizes the reimbursement for CHW services. There are managed care plans that are required to support CHW services, or in some cases not obligated to follow specific policies. And you have the multiple types of organizations that Colby and LyVesha mentioned, and I see a lot of mentions in the chat box. You have your community-based organizations, you have your federally qualified health centers, local health jurisdictions, rural health clinics. There's so many different types of organizations. And so some of the solutions and some of the recommendations that we really encourage you all to pursue. If you go back one slide, Colby, to address this issue around unfamiliarity, we really do want to encourage folks to explore partnerships. Whether you're in a state that is receiving CHW reimbursement or not, we are recognizing that cross-sector partnerships, partnership building, partnership advocacy is really critical. And I'm dropping in a resource here from the Center for Healthcare Strategies. They have a really wonderful partnership assessment tool that you can download and use to help your organization navigate through new partnerships. And there's one more bullet and one more resource I want to share here. You'll see that bullet that says braid funding. For those who are unfamiliar with the concept of braiding, it really involves combining funds from multiple sources to support a common goal, while ensuring that each funding maintains its specific program identity. So you just got to make sure you're tracking it very carefully. And there's also a concept of sequencing. That's when multiple funding streams, you manage them separately and sequentially provide specific services. So I'm going to drop another resource here for those who want to learn more about some recent successes around braiding funds. Center for Healthcare Strategies just did this really awesome webinar yesterday and published this brief, some really great person-centered care lessons around braiding Medicaid funds. So yeah, and the next slide here, just really quickly, if you want to address complicated policy. In the state of California, we have this wonderful community health worker promotora representative policy coalition. I just linked their website here. But there are a lot of amazing coalitions regionally, statewide, and NACHWA is a national coalition that can help navigate complex policies and provide technical assistance. So that's just my two pieces there. So I'll pass it to Colby.
Thanks, Joe. The next two top existing challenges I'll tackle. It's about eligibility, credentialing, and rates, as well as contracting and technical requirements. So, of course, working in this space, working with health systems and health plans is new to many organizations, and it comes with those challenges, right? What does it take to work with a health plan? What does it take to work with a health system that has data managed on their electronic health record system? If you're in a CBO that has never dealt with this data before, do you have what it takes to meet the needs of the organization requirements? So do you have the system in place? Do you have the technology? Do you have the staff in place? Do you have the know-how, the skills to manage and bill in these different settings? So the first one is around who can bill, when can bill, what can you bill for, when can you bill, what requirements are needed in place before to get the approval to bill. These are all questions that organizations ask. And for every health system or health plan you work with, or every state you're in, it could be very different. So that's the first one. Of course, policy is what drives a lot of this work. Sadly, in some states where the policy exists, there may be, however, no operational guidelines on how to implement the policy. And so I've been to many states where the policy allows for reimbursement, but because there's no operationalized guides to implement the policy, organizations aren't utilizing the benefit. So definitely another way to partner with organizations, learn from each other, learn from other states to overcome these credentialing requirements and rates. And of course, if the rates aren't sufficient, like LyVesha always keeps mentioning, that's a big barrier to getting started. Of course, in some states, there's also credentialing requirements around the individual, the CHW. So some states like Michigan requires you to be on the registry. Arizona requires you to have completed their training program or become credentialed. Other states require you to take certain training programs and not, others. And so, and Kentucky requires you to take a mental health first aid course. So different states have different requirements around who can be contracted and credentialed to provide these services. Next is contracting, and I'm specifically talking about contracting with a health plan. And so in some states where you have to be contracted with the health plan or maybe be credentialed by the state, that contract takes some time and takes some know-how to navigate the different online portals or credentialing processes. From one health plan that I work with now, I had to submit over 150 pages of documentation proving how we had the policies and structure in place to utilize these benefits. Of course, the health plan wants to know that you can meet the needs of the health plan. So are you managing data properly with HIPAA compliant SOC 2 and high trust secure software? Are you able to manage high risk and make referrals appropriately? Are you able to verify eligibility of a member that you're providing services to someone who actually has that benefit in place? Do you meet the contracting requirements that the health plan requires, which, they're used to working with health clinics and clinicians. So this, of course, is very new for lots of organizations. Even having an NPI can be new for an organization. So these are certainly some requirements and barriers. Certainly, there are some solutions, of course. There's lots of organizations that are helping groups that maybe are new to this to understand these benefits and being able to get assistance from advisors or other consultants is always a great way to use it. We found in California a lot of success working through the health plans themselves. They want to work with you. Like Sarah dropped in the chat that she wants to find CPOs that she wants to work with. She's willing to help you. And so reach out to these contracting teams and ask for assistance because I think they oftentimes want to work with you. There's also this concept of a hub. So being able to get supported by an agency that can bring you under their wing, help you with contracting, helping you with billing is another model that's really, I think, picking up a lot of traction. So look out for that as an opportunity as well. All right, and wrap it up. We'll pass it over to LyVesha, the last one.
Okay, yeah, like we all mentioned, lack of leadership commitment because of the fact that a lot of the expenses are not covered in the reimbursement. A lot of leaders lose the momentum for continuing this. And I know I read in the chat someone stated, I apologize if I don't remember the name, but I heard something about a lot of CHW positions are dropping off, and then they're picking up the lead care management positions, which falls under the enhanced care management program. And a lot of the services are for CHWs and lead care managers is still the same. It's almost the same position, but just a different title. And but there's more funding supported in the enhanced care management benefit than the community health worker benefit. So that's the challenge right there. We need to increase, and show the importance of the CHW benefit in order to mitigate the lack of leadership commitment. Competing priorities, because there's a lot of other things, IT, a lot of HIPAA compliance, a lot of things that Colby just mentioned are necessary in order to have that contract with the managed care plans. So that's a huge barrier. And then it's a lot of planning. Like I said, in my case, I kind of jumped out there and stopped talking about it and just, jumped in the water, and I'm learning how to swim while I'm in the water. But unfortunately, in some cases, there's not a lot of action. And then there's financial constraints. So if I didn't have different other streams, a source of income, it would be hard for me to maintain this position as an independently contracted supervising CHW provider, because I know the lack of representation in my community. So there are a lot of constraints. There are a lot of financial constraints, but I know the importance of maintaining my position and also advocating for an increase in funding. Some potential solutions, trial and error. Like I said, just jump in, join collaboratives like myself and Joe and Colby. They have been a great asset to my success, and they help me to maintain the momentum to stay in this position and continue to advocate and share my story and share it in spaces like this and create more advocates and more supporters to help spread the message, asking for help. That's another thing I have to do. I have to ask for help. I know the managed care plan, CCAH, probably gets sick and tired of me, but I call them about absolutely everything. So I've had the ability to submit claims for reimbursement since February. And up until now, I still have not submitted my very first claim because I want to make sure I'm getting all the help and all the assistance I need, because when I jump out here and do this, I want to be able to, because there is no model, there is no outline, there is no platform to this. I'm creating it as I'm going. I want to be able to do it the right way. So I'm sharing the correct information in order to inspire more people to, also take this path, because I believe personally, as a CHW, the best CHW supervisors are CHWs with that experience, because we know how to best support other CHWs. I know we're about running out of time, so seek technical assistance from advisory organizations, learn, attend webinars, attend readings, and secure startup funds to cover initial costs to launch, because it does cost a lot. You have to have your own LLC, your own business, your own website, your own insurance, and all of that. So do all those great things and just jump in. Take it, you can do it. If you never try, you never know.
Well said, LyVesha. So we do want to leave you all with some critical resources, some really helpful resources. So one resource is this upcoming webinar. I'm dropping in the registration link to this webinar. This is happening next Tuesday, August 27th. This is a California statewide webinar hosted by, sponsored by the California Healthcare Foundation and the Department of Healthcare Services. And I'll be moderating on behalf of Community Health Synergy, two fabulous organizations that are partnering together to implement the CHW benefit in California. The CBO that's featured, they're called Sowing Seeds Health, and the managed care plan that is being featured on the webinar is Anthem Blue Cross. So please register if you're interested in attending and learning more about what a successful partnership looks like for CHW benefit. The next slide here shows a range of resources that we'd like to just provide as a gift to everyone. So feel free to click on these links. And I know folks have been asking for email addresses. So the next slide shows our email addresses, LyVesha's, mine, and Colby's. Please do reach out to us. We highly, highly encourage you to reach out to ask for tips, tricks, resources. Let's advocate together. CHWs, we love you. And we're just so appreciative for this amazing community and the opportunity to share our insights. So thank you. Colby, LyVesha, any other last words?
Thank you, everyone, for doing what you do.
Yeah.
We appreciate.
Yeah, thanks a lot. And I think we were answering questions throughout the presentation, so I think that's why we're a little behind. But if you have any other questions, feel free to drop in the chat or definitely email us, because we're always available. I always text or call or email Joe, and he's always helpful. And LyVesha has been an amazing partner in our work at CCH. So definitely, I want to thank everyone for being here and thank the wonderful co-presenters. LyVesha, any wrap-up words from you in the last minute?
Just don't be afraid, don't be afraid. Just close your eyes and jump.
Exactly. That's really the best way to get started and learn. Learn by trial and error. So we're now contracted with 12 different health plans in 3 different states, and it's only by asking and learning and trying it ourselves that we learn how to do this. And so it definitely is the best way to learn. But yeah, we'll definitely have the presentation slides available to share with everyone after this. And like Mavis asked, I think we'll try to see if we can get some of the links and the different resources and the questions from the chat in there as well. So, but yeah, thanks so much. I'll hand it over to maybe Sophia. Yeah.
We can definitely make that happen. So thank you everybody for attending, and we will be transitioning to our next session. You have a 15-minute break and then session 2 will start. So please check out some of our other fabulous presenters, and thank you all so much for sharing your time and your resources. This was fantastic.
Bye.
Thank you. Mahalo.